To everybody who's joining us today for CII, IDA Need of the Hour. This evening we have Dr. Matthew Verghese. He is a consultant with St. Stephen's Hospital. Dr. Verghese, it is an honor to have you on our show. Thank you.
Thank you so much.
So, Dr. Verghese, I'm going to just jump right in because, you know, your video has also gone viral and you really talked extensively about your views on protocol and treatment and you know, doc, they've been differing a little bit from the mainstream, I would say, in a way. So Dr. Verghese, could you just touch upon two things for us? One, what is in your view the right protocol and treatment, and secondly, as it relates to possibly the timelines?
Yeah.
To you, Dr. Verghese.
Thank you for having me here, and I'm glad you brought up the most important issue. When I reviewed the papers, and I've been reading papers on COVID right from the beginning, 2019, when the first case report was made in Wuhan.
Right.
So from then on, I have been following up. I've been reading all the papers, and it's very clear that we are missing something in our approach to the disease. Because when a person is diagnosed as positive, and that is when the treatment, you know, aggression begins, and the doctors are aggressive about doing something to catch the drug. So you use all your ammunition that is available with you. So you use your ammunition of vitamins, one set, B, C, D. Then you use your ammunition of antibiotics, doxycycline, azithromycin. Then your ammunition of what are known as in pharmacological terms as off-label use. The label for which a drug is not meant to be used, off-label use. And then there are some drugs which come as emergency authorization drugs. So you try to use everything. And so initially we had HCQS coming up, we had ivermectin coming up, they had doxycycline coming up, we had azithromycin coming up, and the vitamins coming up. And then of course you have the favipiravir, then you have the other antiviral drugs, the whole lot. So when you have a whole bunch, that is my first suspicion that there is something wrong here. You're doing everything, which means you don't know what you're dealing with.
Yeah,
actually. It is a fact. Nobody knew what they're dealing with. So my curiosity was to understand what are we dealing with. So that is what helped me understand this. So the first important understanding is the disease caused by the virus is a very minor disease. Little flu, little sniffle, little cough, little, you know, fever, that's it. Lasts for 2-3 days and it goes away. The major complication, major dangerous turn in the disease comes after the 5th day.
Absolutely, yeah.
5th day of the first symptom. 5th day of the first symptom. And that initially was thought to be because of virus causing a pneumonia. And that subsequently was proven as a big mistake. It is initially thought the virus continues to multiply in a few people, about 80% nothing happens. In the 20%, the virus continues to multiply, continues to cause disease of pneumonia. And therefore, you need to attack with all kinds of antivirals, all kinds of other drugs, and then go on to ventilation if it is not settling. But the pathophysiology, when it is evaluated by a pathologist in Italy, showed that it is not pneumonia at all.
Yes, yes.
It is clotting of blood in blood vessels of the lung air spaces. The air spaces in the lung where exchange of gases take place, clotting happens. So this is the key to understanding the pathology of the disease. Key to understanding this. So if you have a viral disease which is caused by the virus, 80% have nothing else, forget about it, nothing is required now. About 20% of people, after 5 days, have problem, the disease takes a dangerous turn. These are people in whom there is a possibility of clotting, and the degree of clotting, who has a severe degree, who has it, we have no way of knowing. I have no way of predicting. If it is happening, then I can make out by looking at the symptoms. Fever, which is subsided 2-3 days it subsides and then goes up again.
Yeah, yeah.
2-3 days it is low grade, then it becomes high grade. This is a key symptom warning sign that there is a problem in the disease which is taking a new turn. Okay, it's like a turning point
You're
in a novel.
alert.
The
Yeah,
turning
yeah.
point in a novel. Same way it is a turning point in the novel of this virus.
Sure.
And you have to now recognize this turning point. Occasional numbers have a bad deep cough, and a small number have congestion as a complaint. So these are the three. All three may be there, two may be there, one may be there, whatever. But the most important thing is the fever becomes high grade. And remember, fever without crocin. You have to make sure. Most people keep taking crocin. I ask them, why are you taking crocin? So we
Yeah.
have body aches. We're taking one. So stop crocin on the 4th day of your first symptom. And first
Right.
symptom also important to identify it correctly. Not the most significant symptom, which quite often is fever or cough. It may be body ache. It may be a little sniffle. It may be a little running nose. But identify the first thing first, count down, because missing that day by 1.5, 2 days might make a difference between your being on a ventilator or not even needing oxygen. That wide a difference.
But
Just that 2 day
Dr.
gap.
Verghese,
Just the
right.
2 day gap.
That the you're saying like, okay, stop the Panadol, but
Paracetamol.
the paracetamol, yeah. So what would be the context around which you would stop it though? I mean, is it just as a means to test whether how the fever is progressing, or
First symptom, you have symptoms, body ache, backache, whatever. You
yeah,
can take paracetamol. No problem. But usually, evolutionary biologists teaches us that fever is useful for us to fight. Human body, it is useful to
yes,
have fever to fight infections.
yeah,
So don't treat all fevers. Treat fever which is more than 100.5 or 101 degrees. Less than that, you don't need to treat. So up to that, you may up to third day, you can take paracetamol. After that, don't take it, because you may mask the onset of a dangerous turn in the disease. So watch out for fever going up to 101 on the 4th day ending, 5th day beginning, 5th day ending, 6th day beginning. It's plus minus 1 or 2 days.
right.
Usually plus minus 1 day.
Sure. So that's your indication
Yeah.
down. Yeah. Okay. Wonderful. Thanks very much. Dr. Verghese.
When I started guiding, I started guiding patients on this protocol way back in August or September.
Right.
And when I told them about this 5-day thing, somebody put it up on Facebook as Dr. Verghese's rule of 5. Then somebody called me up from one of the embassies.
Yes.
We saw this on Facebook. What is your thought? Do you think it is right? I said, look, I'm testing it out. I do not know as yet.
Yeah.
But at that time of testing it out, now case after case, they consistently tell me, this is what happened to you. You were so right, doctor. You were so right, doctor.
Fantastic. And you know, your experience and you're testing it out to see it. So that's great. Dr. Verghese, I have a question on this whole antiviral cocktail. I mean, you know, Trump had taken it as well. And recently there was a patient in Medanta also. I mean, do you think this is the new line of treating COVID now?
Look, what is this cocktail? First of all, you have to understand. I think I'll go back a little further so that people can understand what it is.
Sure.
Immunity refers to your ability to fight infections. Okay, you have an inborn immune system. You have an inborn immune system which allows you to fight infections. Okay, and that ability is by two systems. One is the humoral system, which circulates in the blood. The cellular system, which is also circulating to some extent, but not the way the humoral system is immediately reaching there. The cellular system is a little slower, but it is still there. So there is a humoral immune system and a cellular immune system. The human immune system works through immunoglobulins, okay, antibodies. These are immunoglobulins which are generated in response to an infection, and these immunoglobulins are then used to fight infections. So a virus infection, or a bacterial infection, immunoglobulin level. There are again, those are different types, the short-term immunoglobulins, the long-term immunoglobulins. Okay, so they generated and their levels rise to fight the infection. Once the infection is off, the short-term ones die down, the short-term levels go down, and then the long-term starts rising up. So there is a long-term memory for these infections. So here also, immunoglobulins are not new. It's not a new thing at all. So I'm just emphasizing that one. That's the first thing.
Right.
Now, there are these monoclonal antibodies which are synthetic. Body creates by its own cellular immunity. It creates its immunoglobulins. Okay. Now, it can also be synthetically prepared now. So these ones were prepared way back in the 80s. And the person who did that and identified it and generated it won a Nobel Prize for that. Now this person then used it for various things. Okay. Now this particular cocktail contains two varieties of monoclonal antibodies. That is what the cocktail is about. It doesn't have multiple things. It has two varieties of monoclonal antibodies. So if you see these drugs that are named, they'll have tocilizumab,
Right.
tocilizumab. Okay, then casirivimab. Okay, you have denosumab. You have infliximab. So many mabs are there. The last three words refer to monoclonal antibodies, MAB, monoclonal antibodies. The moment you see a drug with an MAB name, it is a monoclonal antibodies. So this cocktail, which has been prepared, which the previous president of US of America got, had a cocktail of two monoclonal antibodies prepared by a Roche company.
Yeah.
It's going to be distributed or manufactured by, I don't know which one it is. Cipla is going to do that. And it is supposed to work. Now just look at this. It is an antibody. It is an immunoglobulin. What do? They fight the virus and kill them. Isn't it? So when is the virus active and causing illness? In the first 5 days.
Days, yes.
Not later. Not later. The mistake that everyone has been doing is they'll say, use it in mild and moderate cases. They're not telling you the timelines. Even in this prescription where they are recommending the cocktail,
yes,
which is about 60,000 bucks, 60,000 bucks. Okay. They're not telling you when to take it. They're saying when you have a mild disease or have moderate disease, you take it. But they're not telling you that you have to take it when the virus is actively multiplying. It prevents the progression of the viremia. It prevents the virus from multiplying and eliminates the virus early on. That is the whole idea. Problem is, by the time the patients get to know about their dangerous turn, the viremic phase is over. So that is when the dangerous turn is already this moderate to severe.
Yes.
You understand?
Absolutely, Doc.
If you follow the timelines, you can actually predict this according to timelines and do this. But then just again look at medicine.
Sure.
We have so many diseases, so many very sick patients in our ICUs, in our hospitals. If monoclonal antibodies or immunoglobulins were such a panacea,
yeah,
you wouldn't need antibiotics. You wouldn't have anybody dying because any infection, dying from infection. Because any infection, you have the monoclonal antibody, you have the immunoglobulin, you attack that and you finish it off. It doesn't work like that.
No,
it
so
has not
Dr.
panacea for all illnesses or infections.
Right. So you're basically saying that the Roche cocktail can be effective, but if taken in the right time, right?
Again, timelines become important.
Yeah, taken in the right time.
I don't know the efficacy. Again, remember the authorization, remember what I said? The off-label use, but this is not an off-label use. This is an emergency use authorization. We call it in pharmacological drug authority terms as EUA. EUA. There is another level of authorization which is possible in the emergency situation, which is called compassionate use of drug. Here we use that in situations where the patient is dying. Whether you do something or you don't do anything. So you may try anything, like the last ditch effort you want
Resort.
to try,
Yeah.
maybe it will work. So it's a
Yeah.
compassionate use. But here we have the cocktail has been given emergency use authorization.
Sure. Okay. Doc, what are your thoughts on the DRDO drug?
The DRDO drug. Now, what does it say? The problem is in science, the science of anything in nature or in the physical or the biological sciences have to be an experiment, has to be replicable. So if you
Yes.
say that it works for you, it must work for me also if it is scientific.
Right.
It shouldn't happen that it works only with the Indian Women Network people. It should work
Sure.
with people in St. Stephen's also. It should work with people in Vedanta also. It should work with people in, other government hospitals also. It has to
Yes.
work everywhere. And that ability of a drug is tested in different phases. Phase 1, phase 2, phase 3 trials.
Yeah.
And after phase 3 trials, the results have to be published in what are called as peer-reviewed journals. These are journals where, say, for example, I'm a reviewer for 2, 3 journals. So when they have an article sent to them, they will send, they know my domain of expertise. They'll send the article to me. I'll go through it. I'll go through the methodology. I'll go through the results. Is there any fudging in my assessment? Is the methodology correct? Is the ethics there? Have all the institutional review processes being fulfilled? All those things I look up. And I find anything suspicious, I'll say not acceptable for publication. So any scientific work
Right.
goes for a publication review process. We have no peer-reviewed article on the D2G, the deoxy-2-glucose. We do
Right.
not have a peer-reviewed article to the best of my knowledge as yet. That's one drawback. We do not know, this the drug is supposed to be there for some time, but we do not know all the side effects also. So
Yes.
my professor
Absolutely.
in medicine who taught me medicine, Dr. Mishra, R.C. Mishra used to tell us in the class that, all doctors would know the uses of drugs. Even compounders would know. Even RMPs would know. But good doctors know the side effects of the drugs. I would challenge people to tell me all the side effects of this drug because they have not been publicized. So
No,
we
no,
would like to know them before we can use them. That's one. The second part is it is an analog of glucose without the properties of energy production by glucose. So what does it do? It is supposed to cheat the virus into thinking it is glucose which is using it, but it cannot use it because it is not glucose. So cheating process of the virus. So when would the virus be active? It needs the virus has only one role. One to become two, two to become four to multiply. In,
multiply.
in the evolutionary scale, virus only needs to multiply. It has no other existential role. So
Right.
if it has to multiply, it needs glucose. If it needs glucose, it is energy. And if D2DG is there and it is cheating the virus, it means you're giving it in the early phase.
Again, the phase is so important.
Again, the timeline becomes important.
Yes.
So giving it on the plea that it works in mild to moderate cases. When do you say it is mild? When do you say it is moderate? Is it symptom based? Is it oxygen based? Is it something else? I
Yeah.
need clarity on that. That's my problem with all these reports. When you look at their
Sure.
papers, they do not tell you, they'll tell you about oxygen dropping so much. But oxygen doesn't drop so easily. Oxygen drops when significant part of your lung is damaged. It's a flawed understanding of the disease pathology.
Right. So, Doc, I'm just going to ask you two more medicines. I know ivermectin is one that you've also spoken about. And there's just so much controversy around it. But why do you think people are still dispensing it? And that's one. And the second one is, what about Fabiflu as well? What are your thoughts on that?
Favipiravir is an antiviral drug, which means it reduces the volume of viral load by inhibiting its multiplication and entry into cells. Okay, it was found to be useful in few cases of early H1N1, SARS-1, SARS-2.
Right.
Okay, but it has not been found to be effective in COVID-19, coronavirus 19 infection.
Sure.
Okay. So medically, we distinguish between Corona-19 and COVID-19. When the disease is there, we call it COVID-19. When the disease is not there, just the infection or just the virus is there, it's coronavirus 19. So
Okay.
it has not been found to be effective in that. But since the use started, everybody has been giving it. But remember, it has a lot of gastritis and other side effects, which, I had H1N1. I was prescribed Tamiflu. I did not take a single dose. I became all right on my own. But that's anecdotal. I can't
Sure,
claim that it
sure.
will work all the time.
Right.
But I'm just telling you that I was afraid of the side effects.
Yeah, but ivermectin, I mean, do we
Ivermectin, you know what it is?
yes, there are?
What is ivermectin used for? It is it is an anti-parasitic drug. What are
Yes.
parasites in our intestines? Roundworms. We have these worm infestation in our body. It is given
Yeah.
for treating worm infestation. So how was it found to be effective in this viral infection? It was found to be effective because they found that there are certain enzyme systems of the virus replication phase
Sure.
where it affects the enzyme systems. Therefore, the use was empirically given. When you say empirical, what do you mean in medicine? The empirical use means based on experience, not on hard evidence. So it is
Right.
empirically recommended, and that recommendation has stuck. WHO
Sure.
also is saying there is no role for ivermectin except for in a trial mode. The WHO recommendation is, so we don't seem to say, why do people listen to WHO? Not because WHO is always right, but
Oh,
because
great.
WHO comes to a conclusion on many of these things by using global who is who in the field. Okay,
Yeah.
so I was a member of the committee for trauma in Geneva because
Right.
they picked up handful of people who had done good work on trauma, and they picked them up and they put them together as a committee. So these
Sure.
committees sit together, grade papers. So grading of recommendation for assessment and the whole process of evaluation is done by a grade process.
Sure.
That process has to be gone through, and therefore their recommendations are reliable. So in this particular process, they have found that ivermectin should be used only in trial mode, not in routine use for coronavirus treatment.
Not prophylactically.
Not at all.
Right. Okay. Wonderful. Doc, I mean, you're so familiar with all these medicines and you're, I mean, a man of science. I want to ask you, do you see any medicines coming out in the near future that could treat this?
The honest truth, why? Why? You need to
Right.
understand that also.
Please.
First virus that was discovered in the world, I forget the year, probably it was 1894 or 1904. I forget. You can look up on the net, it's there. Tobacco
Right.
mosaic virus. Tobacco mosaic virus. That is the first virus. It's 120 years now, isn't it? From then,
Yes.
120 years.
Absolutely.
Do we have an efficient treatment for any viral disease? Do we have a treatment for rabies? My own cousin died of rabies. Didn't have a treatment. He didn't know he's got rabies. Otherwise, we would have given a post-exposure vaccine. There's no treatment for rabies. There is no treatment for polio. There is only vaccination for them. There is no
Right.
treatment for measles. There's only vaccination. There is no treatment for rubella. There's only vaccination. There is no treatment for any of the viral diseases, even HIV. There is no treatment because you can only reduce the rate. You can reduce the load. You can tinker with some things.
Right.
Why? Because the virus has no life of its own. Virus to have a life becomes a part of the cell by entering it and then using the cell metabolism to multiply, and that's its only role, just multiply. The only role in existence is multiplication.
So, Doc, how do you see the future of this playing out? And do you think vaccines would be the answer?
Vaccines are the only answer. That's one. But having said that, we've had influenza, flu,
Right.
jabs for quite some time now. What is the problem with that? You have to take it annually. Every year you have to take a jab. So is the whole world getting jabs all the time? No. We're giving jabs only to people that are at a higher risk for a poor outcome from a flu. These are elderly people. These are senior citizens. These are people with compromised immunity. For example, patients of kidney transplantation, patients of liver transplantation, patients of lung transplantation, patients of autoimmune disease who have
Right.
immune suppression given to them, or any of these conditions where you need to suppress the immunity for any reason.
Okay.
These are the people where we would think they are vulnerable and therefore we'll give the jab. So in this particular situation, in the surge that we have,
Yeah.
there is no role for any vaccine to control the surge. Please remember that. Why? Because it takes about 4 to 8 weeks for the immunity to develop. So if you were to look at the, the way the current wave has emerged, it's been huge. It has been huge and people have had a tough time. And if I don't know whether you can see this picture that I'm going to show you. Can you see this?
The graph.
The
Yes.
graph. Can you see the graph? Can you see the small hillock and the steep
Yes.
Mount Everest that is there?
Yes, we can.
Both of them are symmetrical. The first wave is the October-November wave we've had. The
Right.
second spike is the spike that we've just had. And I've been telling this in meetings after meetings that this spike will come down automatically, symmetrically like the climb up. It will climb down as it is. And the earlier wave, which was half the size of the current wave, finished off in about 80 days or so.
Right.
This wave will finish off in it is less than half the previous one. So this will finish in about 35 days or so.
So
In
Doc,
the
what about
next
the
2 weeks,
third wave?
in the next 2 weeks,
Yeah.
anyway, whether you do anything, whether you give vaccination or no, it will still come down on its own naturally.
Sure.
And that is because of a certain degree of the infecting people. Having got infected, overcome the disease or succumb to the disease. 80% overcome. Others, some have mild disease, some have moderate disease, the severe ones succumb to it. So these are the small numbers that succumb to it. The others have survived. So the people that carry the infection from one place to the other, one home to the other, one office to the other, they've all infected each other, then have all subsided. Then it will go down. So at least the infecting population is now immune to the disease for at least 5 to 6 months. We are know for a certainty. I've had in the follow-up of around 300 patients that I'm doing now, I've had 2 patients, definitely 3 now, but the first one, it was all the symptoms were there, but negative, but confirmed 2 cases who got the reinfection. But when did they get the reinfection? After 5 months, not before. Usually you're likely to get a reinfection after 5 or 6 months. So we'll have to wait and see how it evolves. So you're talking about the next wave. That is your question? Yes. I wish I was a medical astrologer. I would have made some millions by predicting to the vaccine companies that, watch out for this and hold your vaccines till then and you can get some extra buck from doing that. Hold your drugs till then, extra buck from there. No, there is no astrology possible here. You could do modeling if the gradient or the number of cases as it is evolving, it is going at a certain rate, you can predict how far it will go, how many people will be infected. Those kind of predictions are possible. But to say that it will happen in this manner, no one has been able to predict anywhere in the world. No one.
Right.
So all these are matters of conjecture. The other conjecture that I've heard, which is going to infect children.
Yes.
Oh my God.
This is a big concern.
How do you know that? Give me one rational scientific reason to say that it is going to infect children. Why? Why do you say it is going to infect children? It's just because they have been infected. There are large number of children have been infected in this wave. Large number, even in India and abroad. So do you think it is because the numbers of infected are less? No. We have no idea about which virus is taking on which characteristic to infect which human being. We do not know. Nobody predicted this wave, did they? If they predicted it and no one listened to them, I would like to hear their credentials. Whether they could predict it, and I want to see whether it is published or not, their prediction is right or not. No one knew that, and it has nothing to do with the governmental action or healthcare workers' action or bureaucrats' action. It is a strain of the virus which has caused this. It is highly contagious. Quite unlike the first wave, one member in a family, one family in a block, but in this episode, everyone in the family, had the disease. It is so highly contagious, including the housemaid and the driver got it.
Yeah,
Might
everybody.
just be, they may not be entering the house also, driver, poor fellow also got it. So everyone has got it. So it's the contagiousness of the virus which has got it, and that's all, nothing else. We have no way of predicting it. No way. My suspicion is these WhatsApp universities and other universities are spreading this hype on
Yes.
the recommendation of vaccine companies who know the in this part of the world, the population of children under 15. Do you know the numbers? In India, 38% is the number of children, 38% of the total number of population of India, which means if you look at 1.3 billion, you're talking about 400 million doses of vaccine.
There you go.
To be given to children, if you market it right. So before the third wave hits, nobody knows whether it hits you or not. If it doesn't hit you and you have taken the vaccine, see, you took the jab, that's why you didn't get it.
Yeah.
Okay, so they can, it's a win-win situation for them both ways.
We'll never know.
Okay, but having said that, it's wise to have the vaccine. As of today, we are still working on the safety features of the vaccines for children. Until that is there, I would hold back.
Okay, thank you so much, Dr. Verghese. We're going to open to audience questions because it's already 6. From Sonil, if a patient who is recovered completely, had mild steroids, 16 mg Medrol, reduced to 4 mg, now has 99 fever again in 18 days, is there anything to worry about? And do we need to check any parameters? And if so, which ones?
Yeah, it is very common. And first of all, I would like to warn that please do not keep taking steroids. Steroids are for a maximum of 10 days. That's it. I give it for 7 days and taper off half the dose that I give on the 8th day, half of that on the 9th day, half of that on the 10th day, which means 16 milligram twice a day of methylprednisolone is the dose that I normally give with a bolus of 42 milligram. And on the 8th day, I give 8 milligram twice a day. On the 9th day, I'll give 4 milligram twice a day. On the 10th day, I'll give 4 milligram, and that's it. But you may tweak these doses depending on the level of cytokine storm. So I have had patients who on the 10th, they had a massive cytokine storm seen by severity of symptoms, seen by all kinds of other parameters that we look at clinically and laboratory investigation. So don't keep taking it for 18 days. No, you need to stop it earlier. Low-grade fever is very common in these people, but you have to see why is the low-grade fever. Is there any associated bacterial infection that is there? So what do I do? So if after 10 days, and you've stopped the steroids and you're again having fever, low grade, if you're again having some symptom, maybe headache, maybe something, you want to investigate. And what do you investigate? You get the blood profile. And simple blood profile is sufficient. And that is, you get the complete blood count, which is important thing is to look at the white blood count. If you have infection of any kind, your white blood count goes up.
Right.
If it is virus related, white blood count goes down. If it is bacterial, which is what happens after taking steroid, after an immune suppression by a bacterial viral infection, your bacterial infection is what comes up, and that invariably leads to increased white blood count. It increases your ESR. It increases your CRP. These 3 parameters are what we look for. That is all that is required. However, some people have been taking steroids for a long period unnecessarily. Some people have the vulnerability because of the heavy load and their immune system is compromised. They are having some of these fungal infections which are vulnerable. Mainly, more than 95% are diabetics, not ordinary human beings. More than 95% are uncontrolled diabetes. These may have sinusitis coming up, which may be fungal. So low-grade infection, you must low-grade fever. Most of the time, again, mostly it is bacterial. And more often, it is just low-grade fever with no other significance. So you just get the blood test done. If things are normal, don't worry. You don't have to worry at all.
Thank you.
You don't have to keep treating it.
Thanks, Dr. Verghese. So, Sonal, I hope that's answered your question. From Dr. Glassy, after you recover from COVID, is there any cutoff for antibody levels to decide should you take a vaccination?
Yeah. The antibody levels are an unreliable index of the ability of the human immune system to fight the virus. Why? Because, as I said in the beginning, there is a humoral antibody which is circulating, and there is a cellular antibody reaction which is cell mediated. So you may have low antibodies which are humoral but very good cellular immunity. Low cellular immunity but good other antibodies. So you cannot predict the ability of that human being to fight the virus by just looking at the antibodies. So we do not recommend using the antibodies as an index to decide on vaccinations,
right.
to decide on need for protection, or to decide on isolation, to decide on anything. Okay. And decide on post-infective immunity buildup. We don't decide on that at all. Not reliable.
Okay, great. Thanks very much, Dr. Verghese. From Prachi, for those who are pre-diabetic or have early stages of diabetes, is there an alteration in the course of treatment that you are suggesting? Or is there something specific that they need to be mindful of?
Yeah. Steroids. What are steroids? How did nature, we evolved in human evolution, Homo sapiens erectus. Those of you who are interested in evolutionary biology, it took us millions of years of evolution. 5 million years to evolve into mankind. 5 million years. Okay, because that evolution has built in certain protective mechanisms for the survival of the species.
Right.
That's the only role of evolution. Life is there for existence and multiplication and death. There is evolutionary biology, there is no other role for existence. We create a meaning in life, that's different. We find a meaning in life, that's different. But evolutionary biology teaches us viruses multiply and die. Bacteria multiply and die. Human beings may or may not multiply and they die. There is no other evolutionary role there. Some of you may argue theologically against me, but that's a different discussion altogether. But this discussion is steroids came into being to help us survive our species. Right. These are drugs of stressful situations. And in stress, in the jungles of yesteryears, what was essential? Physical ability to run, physical ability to fight, physical ability to climb. What does that need? Glucose. So if you have a steroid being released in response to an emotional stress or a physical stress, the body releases steroids. And the steroids increase the glucose levels in our blood. So steroids are evolutionary biologically diabetogenic. So if you have diabetes or you're a pre-diabetic or you're a stress diabetic, when you give steroids from outside, it stimulates the glucose level in your blood. So your blood glucose level control goes haywire. Your need for tablets may double. Your need for tablets may still not be sufficient. Even if you double it, you may need to go on to insulin.
Insulin, yes.
Need for insulin dose may go up. That is why I tell people, don't start steroids on your own. Under the oversight of a physician who understands your biology, understands your problems, understands your comorbidities, and then gives it.
Sure. Thanks very much, Dr. Verghese. From Rinki, what should be the protocol for people who have mild fever every day, but seem to be testing negative for COVID?
I need to know which phase of the disease in timelines you are in. Are you in the first 5 days? Are you in the second 5 days? Are you in the third 5 days? Or are you in the fourth 5 days?
Let's ask her to answer that.
In the first 5 days, it's viremia and the fight between the virus and the body's acutely generated antibodies that are fighting, causing firework and fever.
Right.
That you can take paracetamol. The second 5 days, it is part of a cytokine storm. It will not be a mild fever, it will be a slightly more than mild. It will be 100, 101. It may come down to 99, but it will still be a high degree sometime in the day. Usually it will be worse in the evening. Why? The steroid levels, natural steroid levels in our body are lowest in the evenings. That is why when we get up in the morning, we feel fresh, steroid levels are high. When
Right.
we go in the end of the day to back home, we are tired and exhausted, steroid levels are low. So that level fever may vary, but it is still there. And that needs to be managed as a cytokine shower or storm. The third 5-day period, fever may be a harbinger of bacterial secondary infection to
Right.
steroid that you've taken.
Yes.
That will need assessment by laboratory parameters and treatment by laboratory parameters guiding you for antibacterial antibiotics. The fourth week can be a different thing altogether. This is a special category of patients who may have been in the 20% of people who have had
Right.
cytokine shower and storm have now come to the recovery phase. This group of patients have a fourth phase of cytokine shower. They may have low-grade fever. These are the ones that have cardiac problems, children with rapidly rising heart rates, rapidly slowing heart rates, 40 heart rate. Sir, my heart rate is 40.
Yeah.
Adults having heart rate of 140, heart rate of 40 to 46. These are immune-mediated myocardial damage patients. These need to be shown to a physician or a cardiologist. They may need bolus steroids and they may need other drugs recommended by a cardiologist. So which phase of your disease are you in? That's why the timelines again repeat. Timelines
Important.
and protocols.
Absolutely, very important. So, Rinki, I hope that's answered your question. From Shiv, do you recommend that Perfinex be taken for pulmonary fibrosis post-COVID? And if so, for how long? And maybe you can also just suggest the dosage as well then.
I don't like to give in such a general population. I don't like to give dosages. So I just
Okay.
mentioned these steroid dosages because I thought I'll just tell you how I halve it. That's all. That's the reason I gave it. But there are
Okay.
different types of steroid that are possible. Perfidinate is a drug which has been found to, it's very expensive drug. It will cost you quite a lot. It will cost you about 1.5 lakh for a course of treatment. Yeah. So that drug is decided to be given, say for example, you've had a cytokine storm, you needed oxygen, you were in the ICU needing non-invasive ventilatory oxygen system of 60 liters per hour, and you have had a significant CT scan score of maybe 19 to 23, and you have significant lung disease. Okay, now such patients, as they recover, they may have a COVID pneumonia with bacterial infection that may also subside with good antibiotics and good medical oversight. All well, happy, it's a hunky-dory situation. But a small number of these patients, when they reach the third week, they stop improving in their lung condition. How do you know they stop improving? Because their oxygen requirement came down from 60 to 15 to 6 liters per day. It doesn't come below that.
Sure.
It doesn't come below that. 4 liters per day. You take off 4 liters, they are breathless. The saturation goes to the 80s. Such patients may be developing fibrosis in the lung, which will prevent full recovery of the lung. So if you look at CT scans of these patients, 4 weeks down the line, a lot of them show a lot of clearing up. But a small number will show bands running from outside of the lung right till the inside, bands. Now, if there are bands that are fibrotic, and the fibrous tissue has a peculiar characteristic. Fibrous tissue is inelastic. Normal tissue has an elasticity like this. It's
Right.
elastic.
Yes.
Fibrous tissue is inelastic. It doesn't stretch.
Okay.
Now, if you have fibrosis coming in your lungs, the lungs inflate by increasing its capacity in the chest wall. It is attached to the chest wall, not attached, but there is a negative pressure around it. And
Sure.
as you inhale, the lung expands and you have the oxygenation going in, the air going in. When you exhale, it shrinks and throws out air. So expansion happens with inhalation. And if there is an inelastic band holding up the expansion, the aeration will not happen. You will become breathless because lung is not expanding. So to encourage this expansion, you have to prevent the fibrosis. To prevent the fibrosis, you have perfidinate being given as a drug. It is still not a completely 100% effective drug. There is an element of uncertainty about it. There is an element of uncertainty about the protection provided by it. But if you're not improving, and I've described the kind of patient that he needs it, you will give it.
Sure. Thank you so much for that, Dr. Verghese. Okay, from Megha. She has no antibodies despite 2 Covaxin jabs. Should she consider taking a Pfizer or a Moderna a few weeks or months from now?
Not at all. Not at all. As I said earlier,
Right.
the level of antibodies in your body has nothing to do with your level of protection. It is unreliable index of protection. You may have a very efficient cell-mediated immune system.
Right.
That will take care of the virus. Don't worry. Don't worry. Don't go by that.
Okay.
But can I say it for a certainty? No, the proof of the pudding is in the eating. Unless you survive an attack, I can't claim that what I'm saying is true. But the fact remains, it is an unreliable index, and therefore it has been given up as a measure to check for the protection provided by the vaccines.
Sure. Thank you. From Rinki, post-COVID, please highlight the protocol to be followed for symptoms such as headaches, pain under the eyebrows, and pain near the sternum.
Okay. Now look, post-COVID, there are several things that happen. Post-COVID, you have an immune compromised status because it is an overwhelming infection and your entire body, it's just like when you're fighting an enemy from the border, across the border, without naming any country, your whole army is there. But if the whole army is there, there's an internal strife, you have a tough time controlling that, isn't it? The same logic here also. Your whole immune army was fighting the virus to eliminate it and successfully eliminated it. There is a transitional phase where your immune system needs recovery time. It needs a rest and recovery time to come back to its normal state of good resistance to regular infection. If such people also happen to be diabetics, whose immune system is already compromised, also happen to be renal transplant patients, also happen to be other patients on steroids, these people are vulnerable to other infections, which are known as opportunistic infections. I'm sure many of you are familiar with probiotics.
Yes.
What are probiotics? If you read the thing there, it will say it contains so many millions of this bacteria, so many millions of this bacteria, millions.
Yeah, good gut fight bacteria.
Not hundreds, not thousands, millions. These are useful bacteria which are living as a commensal in a happy, healthy, coexisting mode with our body and our body systems. These probiotics, they have a useful role. When you have a viral infection and you have a bacterial infection and you give prophylactic antibiotics, you eliminate these useful coexisting bacteria also. Coexisting all organisms that are sensitive to these antibiotics and antiseptics. You're left with a field that is clear for fungal infection. That is why fungus is common. So it is not just steroids. It is not just steroids. It is not just diabetes. It is not just uncontrolled diabetes. It is also the COVID infection itself. It is also those patients who have COVID infection have lymphocytes going down. All these coming together, not one factor, which contribute to the symptoms that are there, which could be headache. Again, if it is there in the 3rd week, you could have gone home after steroids, after diabetes uncontrolled, you may have headache because of sinusitis. Sinusitis could be from bacterial infection also, secondary bacterial infection. So you need to look at what is causing that symptom and look at what is causing that. So investigate for that mild fever. Investigate for that. Maybe you need a paranasal sinus X-ray or a CT scan, or maybe you need a nasal swab to check is there a fungus. It is not just black fungus. Any fungus can grow. So we are seeing cases of not only black fungus, we are seeing cases of green fungus, we are seeing cases of white fungus. They are all there. It is an opportunistic organism which normally is there. It's there all over. Don't think it has come from outer space. No. Don't think it is because bioterrorism. No. It is there in your regular garden soil. The spores are there hanging around waiting to multiply when the soil is fertile. The soil is fertile when it is warm, when it is moist, when it is acidic, and there is lots of glucose there. It thrives.
Absolutely. So, okay, thank you so much, Dr. Verghese. From Tanvi, she's basically, I mean, she's written it long, but she's just asking, saying thank you, and she's asking, how does one differentiate between the body aches, throat irritation that are...
For those of you who can see this, that is a black fungus culture that you can see. Can you see that? That's how it is. It is black. Initially, it is white. It is black only because the spores are the seeds. It's not medical and it's not biologically called seeds, but these are the seeds with which they germinate. And then here is another one. Can you see that? Again.
Yes.
Green fungi. So these are the ones which are there. Don't get scared. The numbers are very few, but they are still there in absolute numbers. In absolute numbers, before the COVID also, India and China have 70 times the global figures of fungal infections of the paranasal area. 70 times the global. Probably.
Why is that, Doc?
We don't. It's part of the soil that is there.
Right. Okay. So, Dr. Verghese from Tanvi, we've got, thank you very much. And she's just asking, how does one differentiate between, the typical symptoms of COVID versus those which are like lifestyle and pollution oriented? So, for example, body ache, throat irritation, cold. How do you know? And she's also had a persistent backache for a month, which she says comes and goes. So how do you know that, what is it COVID related or not COVID related? And when should, how should one decide to isolate or not?
Yeah. See, if it is corona, 80% will just have a little cold and cough. So in today's time, if a person comes to me with these symptoms, I tell them very clearly, consider it as corona unless proved otherwise, period.
Okay. Yeah.
So high indexes, because the outcome can be dangerous in 20%. Therefore, you want to be careful. You don't want to leave anything to chance. But when I talk to patients, sir, I've had a cough for 1 month. I've had a backache for 1 month. No corona patient will have a backache for 1 month. Okay, no corona patient will have a cough for 1 month. No. You may have a little sore throat which comes. You would have gone through the symptoms of corona turning severe, but the mild ones will not have a cough for 1 month. It's only the severe ones with severe lung involvement who may have lasting cough. But by then you would have known he has had corona. So the rule is suspect corona unless proved otherwise.
Okay, great. Thank you so much. From Nandini, she's asking, how long does it take for the lung fibrosis to recover after you have had COVID?
Very difficult to answer that question. A very close friend of mine, he had the symptom. He went into the ICU, was in the ICU for almost 2 months, recovered, was found to have fibrosis in the lungs on CT scan. He is now 4 months down the line. He's still breathless. So we've no idea. He's had the perfidinate drug also. Right. No idea how long it will take. But I've had a patient who came to me yesterday. He came and met me just to thank me because he was at home. His whole family was positive, and I was guiding them treatment at home. And I started the Monstera dot on the right time.
Right.
Followed the timelines. Yet he needed to. So by this protocol, can I predict everyone will stay at home? No.
No.
you will still have a bad cytokine storm. Some of them will have it. So
Sure.
this young person he was also diabetic. He had the problem and he went on to 2 liters, 6 liters, 50 liters, 40 liters,
Wow.
that gradation. His CT scan score when he got admitted was 7. 1 week after admission was 17. 5 weeks after admission and discharged back home, he recovered, went back home. You know his CT scan score? 23.
Oh, wow.
He was walking 23 out of 25, which means he had only 8% of his lung tissue functioning. 25 into 4 is 100%.
Yeah. Yeah.
2 into 4 is 8%. And he was managing, he's breathless on walking, yes, but is gradually exercising and intensive lung exercises. So the therapist will guide you, the pulmonologist will guide you. You will need to have inspirational spirometer, those 3
Yes.
balls that are there.
Yes.
It costs about 1,500 bucks, probably higher or lower depending on where you get it from and
Yes.
what brand you're buying. It may be none of my poor patients. I deal with a lot of poor patients. None of them can afford it. So what do I tell them? Go to the market and buy balloons.
Yes.
Every 2 hours, inflate 3 balloons. Don't have balloons? Take deep breaths.
Right.
Do that. Every 2 hours.
Right. Dr. Verghese,
Exercises, and if you're getting breathless on lying flat on your back, lie prone. But lying prone in the first 5 days of disease doesn't work. You don't need it.
right. Dr. Verghese, you just mentioned something that he was operating on 8%, right? The friend of yours that you were talking about, that patient. So can you tell us what percentage of lungs have to be functioning for you to be at 100% optimal as an
This is one thing which everyone in the world missed out. And I actually happened to understand this because of my residency days.
right?
Where in severe tuberculosis, I'm talking about 40 years back, and severe tuberculosis days, when we had only 3 drugs for tuberculosis, streptomycin, INH, thiacidazole. Okay, and many of them would get bad cavitational fibrocases, tuberculosis. That lung is not functioning, recurrent infections, so they're advised removal of one whole lung because of bad infection. Is the other lung normal? No, that's also has got tuberculosis, but this bad lung is removed. Do they have 80% saturation? No, they also have 97, 98% saturation. So 50% is gone.
There is the question.
Still good function. So I remember that I called up my friend who was a lung transplant surgeon in Hong Kong. I asked him, Shubhe, tell me, if you are doing lung transplant, you do one lung anesthesia, you do one lung anesthesia. He said, yes. So when you clamp one lung to remove it, what is the saturation? It is 100%. Even if the other lung is diseased? He said, yes. So supposing you drop that 100%, so what are you giving to the patient? He said 100% oxygen. So supposing you reduce that oxygenation that you do, will it come down? He said, well, theoretically, yes, but we'll have to see how much of lung is involved. I said, in the next case, can you do it? As an experiment, he did it for the very next day. He had a lung transplant case, interstitial lung disease. This is Hong Kong, huh? And he brought the levels down gradually to 21%. So there's no risk, because if it is falling, you can bring it up again immediately, bring it back to 100%, no risk. He brought it down to 21%. And what was the reading on the monitor? Saturation, 97%.
Wow.
So we know that for normal day-to-day sedentary activity, we need only 1/3 of our lung.
Amazing.
So if you have a digital sensor and sit at home, for that saturation to drop below 93%, you're waiting for 2/3 of your lung to be damaged. And that is why all those people who had saturation dropping, reaching the hospital Within 2 days, he didn't give us time. No, he just went down rapidly. In 2 days, he was on a ventilator. You waited at home with that saturation ruining your lungs. In 2 days, you went on a ventilator. Yes, that is expected. That is pathophysiology of the disease.
Okay, Doc, I know we are really over.
It sounds scary, but that's the truth.
Yes, Dr. Verghese. We still have audience questions. I know we've now been going for an hour. If you have a few more minutes, we'll take 3-4 more questions. If you're,
I'm okay.
Okay, great. For Shibani, we can make it really quick. Shibani is asking, is it safe to sit outside in our gardens or terraces?
Absolutely safe.
Okay.
As long as there is nobody in front of you breathing towards you without a mask.
Right.
There is nobody around you. You can happily stay outside in your garden without the mask also. But if there are people around, this is your only protection. So I would say that if there is one, people don't know how to wear a mask. People today morning also they came, they have the, don't touch this part. Okay,
right.
Don't touch this part. Always use this, wear it nicely, tighten it there, wear
Right.
it, tighten it there. Put this is an N95 mask. Pinch this, nice, snug fitting.
Sure, sure.
Don't touch it here. If you have touched here, then you need to use the sanitizer. That sanitizer again has to be liberally used. So I don't have it far away. Otherwise, I'll demonstrate how to use it. Liberally used. They have a little small bottle. It doesn't work. It just doesn't work.
Right. So just as a follow-up to this, Dr. Verghese, how is it that people in the US and the UK are mask-free? They've had their vaccinations.
That's it. So you have this.
Sure.
Use it liberally.
Right.
Not a little bit on this. No, doesn't work. That's what most people do. They have a little bit on the little bottle on their purse hanging there, and they use it and think they are safe. They're not safe. And when you're wearing this, don't let it come out for talking. Out of courtesy, many of my patients, when they come to me, they bring it down. Doctor Sahab, wo na 4 din se khasi hai. No, don't do that. I tell them I could be infected and I could give you the infection. Then they get scared. Then they immediately put it back.
True. So
and when you take it off, don't touch the side, take it off using the strings. And after this, you have to use the sanitizer.
Yes.
Don't leave it like that. You have to use the sanitizer again. I have been in my outpatient and then in the theater. As soon as I touch it, again do this. Yes. Yep. Go ahead.
Okay. So how is it?
In the US, they haven't opened the flights to everyone. They have only their local strains so far. We're not sure how the imported strains will behave. So as a medical person, we continue to be apprehensive. We will continue to use this. Right. I would not recommend being without the mask, even if you're in the US.
Right. From Neha.
But remember, US is a big country, open spaces. You know, India is a crowded country. Okay, they have only less than 300 million people.
Right.
We have 4 times that population in less than 1/3 the space. 4 times the population.
Absolutely. From Neha, we have, are there studies that support lowering of temperature using paracetamol in a viral fever? So she's got a different perspective, and Neha, I know your perspective, but we will let Doc answer that. So Dr. Verghese, what's your view on paracetamol before it touches 102, let's say? Is it better to let the fever fight the virus?
Yes, that is what evolutionary biology teaches us. As doctors also, we tell patients, don't use paracetamol unless the fever is more than 101. That's our recommendation. Again, paracetamol needs to be used with caution in patients with liver disease. Yes. It's a very safe drug, but patients with liver disease, cirrhosis of liver, portal hypertension, you have to be using it with caution. Sure.
Thank you, Dr. Verghese. So Neha, your takeaway is 101. That's the floor. From Shivani, she's asking, what is your advice around zinc? Because everybody, seems to be really, the jury's out on zinc and vitamin C and D3. So, Dr. Verghese, what's your perspective?
Okay. Your vitamins are part of your metabolic processes. So the vitamins are useful for your metabolism of your cells. The metabolism keeps the engine of the cells running and keeping you alive. So it is essential. So vitamins help the enzyme systems that run your machinery of your cells. Very simple. They are the oil that keep your machinery running. Fair enough.
Fair enough.
Now, vitamin C, Linnaeus Pauling won 2 Nobel Prizes for that. He found that it's critical role in metabolism of cells. So for metabolism of your cells to generate immunity, it is useful. Vitamin B, again, the B group of vitamins are extremely useful for metabolism of cells. Again, for building up immunity, antibodies, it's useful. Vitamin D, the active metabolite, okay, the dihydroxy metabolite of vitamin D is found in one study from UK to be helpful in the early viremic stage to fight the virus. Okay, but if you take, say, cod liver oil,
right?
CII has a large eastern presence in Bengal, so we get our vitamin D from our fish. The classic Bengali would say. So sure enough, we do it. And if you've been taking it for a long time and you're not a vegetarian, it's okay. But the vegetarians don't have vitamin D coming in their food sources. It comes only from animal proteins. That is why, if you remember the elderly, I don't know how many senior citizens you have in your audience, they would remember Rathan Dalda, vegetable fat, which had fortified with vitamin A and D. Okay. Now, if you've been taking D regularly, cod liver oil regularly, it's okay. If you've not been doing it, the active metabolite comes from metabolism in the liver and kidneys, and that takes about 5 days. By that time, the virus has had its killing.
Right.
So before that, you have to have the active metabolism. That's why vitamin D is useful. Now, zinc is an element which is again useful for metabolism of human beings. Therefore, zinc was touted as a useful drug for immune development. That's why zinc plus other vitamins were essential for this. Now, where is the catch? Came up, but when it comes to fungal growth, zinc is essential for fungal growth. There's one more element which is essential for fungal growth, that is iron. And anyway, when you have an infection, many of you may not know this, when you have an infection, you are not supposed to take iron as a supplement because the bacteria use iron for its metabolism to multiply.
Wow.
So we do not want to feed the bacteria iron. We do not want to feed the fungus iron for its growth. Right. Similarly, zinc is also useful, not as useful as iron. Iron is the most useful element, not as useful as iron, but it is also used. Therefore, there is a scaling down. So one solution brings another problem. Another solution brings another problem. So I think it's a dynamic process. We need to learn, and we keep learning.
Sure. From Shibani, are people who have a hyperactive immune response build up to vaccines, fibrostic lumps, are they more prone to a strong cytokine storm?
We do not know the characteristics of people that develop a bad cytokine storm. As clinicians, what we have been finding is brothers, both have gone, both have died. Twin brothers, both have died. Mother, daughters, both have problems. But father is a different genetic pool. Father hasn't had anything. Mother and daughters have had. Okay. In-laws haven't had. But the biological gene transmission, we have seen that. But these are all anecdotal inferences from anecdotal cases. Unless we have hard scientific data, we cannot say anything. But we do not know who will have a bad cytokine storm. There is no way of predicting it. The only way is to see the signs of an early cytokine shower before the storm hits you, exactly as the storm which hit from Bay of Bengal, isn't it? We knew the way, we knew the low pressure. Low pressure was a harbinger of the storm. Similarly, high fever is a harbinger of your cytokine storm.
Thank you so much, Dr. Verghese. From Rama, we have, I've recovered from coronavirus. When do I take the vaccination? So I guess how much later after recovery?
Let me tell you the biology, then I'll tell you the logistics, and then I'll tell you the regulation.
Sure.
The biology is, when I mentioned the first 5 days symptom, the virus has come up, the antibodies is rising. The first interaction between the antibodies and the virus, the fireworks are there, and you have fever. No, great, because of that interaction. At this stage, you have the problem of fever coming on.
Problem of, I didn't catch that.
Of the fever coming on.
Of the fever coming on, right? Okay.
Okay. At this stage, you have the fever coming on, so you deal with that by doing that. But when you have a cytokine storm, it is because of antigen-antibody interaction with clot forming in that, and that is what is causing it. Okay, so that is a completely different mechanism for that. Okay. So when you're dealing with this antigen-antibody reaction, that is fought by an acutely formed antibody. Okay, these are IgMs, early antibodies. They rise and fall quickly. There is a delayed antibody, the IgG, which rises and comes up in 3 weeks or so. Okay, so a person who's had the recent infection will have high levels of IgMs, yes, the acutely fighting antibodies. So these acutely fighting antibodies, what do you do in a vaccination? What do you give? You give either the killed vaccine, killed virus, or an inactivated virus, or an RNA tweaked not to cause the disease, but only have the unique identification of the virus to produce the antibody. So your body, if the antibody is there, it will recognize it and fight it and kill it. You will not have the benefit of the vaccine.
So wait a bit.
Because your acute antibodies will kill it.
Yeah.
Okay. But the delayed antibodies, they don't work like that. They don't rest, they take a little while. By then you will have a booster of antibodies that are delayed. Therefore, it is useful. Now coming to the logistics of it.
Right.
We have shortage of vaccines. Therefore, the government is saying that we will give it to you only after 3 months of your last infection. Very simple.
Yeah. There is a reason for that.
There is a science and there is a regulatory and logistic reason for it.
Right. Okay. Thank you, Dr. Verghese. From Tanvi, she's asking, can you please suggest protocols that we should be following for post-COVID recovered patients to improve their immunity?
The only thing that I can suggest is have a balanced diet.
Okay.
Okay. And I always tell, in fact, I deal with a lot of kids, I'm an orthopedic surgeon. I'm a carpenter of physicians, I do nuts and bolts surgeries every day. Today also I've done my lot. I'm into this purely accidentally. So I deal with a lot of kids. And the parents come in, Dr. Saab, ये बहुत junk food खाता है. क्या खाता है? So रोज इसको पिज्जा चाहिए होता है. पिज्जा चाहिए होता है, बर्गर खाता है. I tell them, sorry, I don't agree with you. Okay, रोज खाता है क्या? नहीं डॉक्टर अंकल, मैं रोज नहीं खाता हूँ, 3 हफ्ते में एक बार ही खाता हूँ. The child is intelligent. So what is the message? There are no junk foods. There are junk proportions of food.
Absolutely.
Well, if you're having aloo ka parantha with asli ghee 3 times a day, that is worse than your burger. Okay, there are junk proportions of food.
Mm.
So what you need to do is you get different minerals from vegetables. You get different vitamins from vegetables and different proteins. And the quality of protein is not the same in all pulses. Your mixed dal may have a richer variety of proteins and amino acids. Your,
Sure.
for example, your urad dal has more phosphoric acid. That's why it is slimy. So these are details which are there, all nutritionists know it. So if you have a monotonous variety of food, that is not healthy. You should have at least one colored green vegetable in a day. You should have balanced amount of protein. You should have less amount of carbohydrates, which is what is diabetogenic. You should
Mm.
have less amount of fat, which is what is high cholesterolemic, dyslipidemic. So all these are things which are known. Have a balanced diet. If you think your diet is not balanced, get in touch with a nutritionist,
Right.
not a commercial one, not a commercial one, but a regular altruistic nutritionist who guides you correctly on what needs to be done.
Well said. The altruism is very important. So, and now the last question from the audience, from Rashmi. My 22-year-old daughter had an ear infection during COVID, and it continued for a week post-COVID. She's now cured, but there were no blood tests ever done. Do we need to do any blood tests now to check parameters? She is slightly anemic.
How do you know she's anemic? She has not done a blood test. Does she look anemic because she looks pale? She lost the color of her face. If she
Right.
lost the color of her face, then I would certainly get a blood test to look at her hemoglobin.
Sure.
Do you need testing? No, you don't need. When do I get testing done? So 80% don't need any testing, except to be sure that they have corona and RT-PCR. But in this wave, 30% false negative. 30%. 30% false negative. Okay. So therefore, you would miss a large number also.
Right.
But then for
You
this,
just added that the girl has, it's a
I've read that.
Okay.
30% false negative. So you still want to know whether you're positive or negative, and therefore for clarity of peace of mind. Okay, that's one. Two, after that, if there's no symptom, I get nothing done. When the cytokine shower symptom is coming, I still get nothing done. But they're very keen. So at best, I get a CBC, ESR, CRP, nothing else. Do I get a D-dimer? No. Do I get a serum ferritin? No. Do I get an LDH? No. Do I get a procalcitonin? No. But if after 4 days of steroids, if they again have fever coming back, if they have more symptoms of breathlessness, I get everything done.
Right.
That's when I get things done. Or when 3 weeks down the line, they're having a problem, again, I'll get D-dimer, serum ferritin and things like that done. Then I may get a CT scan done. I may get an MRI of the heart also done at that stage if it is required. Very, very small numbers.
Sure. So
1 in a million, perhaps. And for this particular case, if there is a past history of anemia, maybe thalassemic, thalassemia minor or major or whatever, maybe minor, or there may be chronic, absorption problem of iron, then you may need to consult a hematologist or a good physician. The good physician will answer. So the rule in anemia is don't start treating. It could just be a simple hookworm infestation used to be the most common cause for anemia in women in villages. Children.
Right.
So, or these days in slums and poor villages, malnutrition. So essentially green leafy vegetables are good source of iron, and good protein diet will provide you hemoglobin that is required. All that you need is that. But if there is a past history of anemia, please seek help from a good physician who would investigate first, find out the cause of anemia, only then will give you medicines. Otherwise, if he gives you iron and B complex and neurobion and etc., buy the medicine, but don't give it till you found out the cause.
Thank you so much, Dr. Verghese. So just before we close this session, how has COVID been for you personally?
Traumatic. Absolutely traumatic. You touched a raw nerve. I sat through the night 2.5, almost 3 weeks, every day dreading that phone call that came to me. Doctor uncle, meri maa ko bacha do. Doctor uncle, mere bhai ko bacha do. I can't bear it. I'll break down. Sorry. And I lost my teacher, my mentor. I can't bear it.
Well, I have no words to just say thank you. You have been such a light for everybody, and it's really, we are in gratitude to you for coming. And
I am in this only to save lives. Only to save lives. I am not here for anything else. This is not my job. This is not my job. I'm not a physician. I'm not a COVID expert. I just read and just talk to patients in detail every day, twice a day, to find out how their symptoms evolved. That's all.
Honestly, I mean, with real gratitude, I really mean it from my heart. Really, really honored to have you just share your wisdom, your sincerity. Everything that comes through here is, you've just been a light for everyone on so many levels. And really, really want to thank you for that. And thank you so much for coming for CII's Need of the Hour. It's been really beautiful to have you with us. Thank you so much, Dr. Verghese.
Thank you. God bless.
And for everybody joining us with for Need of the Hour, on Monday, we have Miss Vanita Uppal. She's director of the British School, and she will be talking about revolutionizing education and how COVID has played a key role in that. And Tuesday, we are closing our COVID series with Need of the Hour with Sister Shivani, and she's going to be talking about building emotional resilience. So please do join us for our final 2 sessions, Monday and Tuesday. Thank you so much for tuning in to CII IWN's Need of the Hour. Good evening to everyone.